I think most of the people here know our speaker for today. She's the professor in the Department of Microbiology and in the School of Medicine. And Dr. Paterson did her undergraduate work at the Manchester University. Is that in Australia or England? UK, okay. But got her BA in biochemistry, by the way, but did a BA in mathematics and philosophy at the University of Australia, which is confusing to me, but that was okay. She received her PhD at the University of Melbourne. As a professor of microbiology, her research interest has been in the field of cancer vaccines, which she will be talking about today. She was the first investigator to use bacterium as a vector to target tumor cells. So without any further ado, here she is. Thank you.
Thank you very much. Thanks very much for your introduction. Should I be wearing this, by the way? I should? Okay. See if I got a pocket for it. So what I want to do today really is not just to talk about my own work. I do have some slides on my own work, of course, because I'm quite proud of it. But I want to give you an overview of what's going on in terms of cancer immunotherapy. Because, you know, in the last, 2 or 3 years, it's really hit the news. It's clearly caught the imagination of the public. Science declared it breakthrough of the year a couple of years ago, cover of Science magazine. Time had an article on inside the brutally selective, hugely expensive, life-saving trials of immunotherapy. Actually, Newsweek had a similar article. So I want to review different aspects of immunotherapy, where they are in terms of development into the clinic, and also what they cost, because they are not all hugely expensive. I hope I can convince you of that. So let's go back a bit and think about what is a tumor cell? What is a cancer cell? And these are some of the common properties of tumor cells. We know what they are. They fail to respond to the regulatory signals responsible for normal growth and tissue repair. They go autonomously. They don't have a requirement for growth signals. More importantly, they invade through tissue boundaries, and they metastasize. Bits of them break off and enter the lymphatics and the circulation and seed the cancer elsewhere. They all come from one renegade cell. There's a wonderful book by Robert Weinberg called One Renegade Cell, which tells you the history of cancer genetics and cancer discovery and how we found out how cancer arises and differs from normal tissue. One renegade cell. But in fact, they can change and mutate and become heterogeneous as tumor mass increases. But the thing is, the property that's so very important for cancer immunotherapies is this sixth property: differences in appearance, a high rate of mutation, and antigenic display from non-transformed cells of the same tissue origin. So what that means is that tumors differ from normal tissue. Either they have mutated proteins that are different from self-proteins, or they've started to overexpress proteins which are normally silent in normal tissue. And perhaps the immune response can respond to that. This is a very old idea, very old idea. Here we go. Paul Ehrlich in 1909 described this idea. Frank Burnett, Nobel laureate, put forward the concept of immunological surveillance. And that this concept states that a role of a function of the immune system is to control the outgrowth of cancer cells by eliminating cells bearing malignant mutations. So the idea is that our immune system is not there just to fight infectious diseases. it's there to control cancer, and perhaps in most of our cases it does. But it isn't effective for all people. We know that patients do mount immune responses to their tumours. We can see in their bloodstream antibodies to their tumours, and we can often see T cells infiltrating their tumours. So we know that the immune response can respond to changes in tumours, to this antigenic display that differs between tumours and normal tissue. Here's another pioneer in terms of cancer immunotherapy. This is William Coley. He was born in 1862, and he was a surgeon in New York. He found that when he operated on patients with cancer in the hospital, they often got serious bacterial infections, which was the norm for hospitals in that era, prior to antibiotics. And when they did get a serious bacterial infection, the outcome was good in terms of their cancer. Their cancer went away. They were mainly sarcomas that would respond to this. And so he contacted Dr. Robert Koch in Germany, and he got a number of gram-negative bacteria from Dr. Koch, and started deliberately infecting patients with these bacteria as a form of cancer immunotherapy. And the kind of immunotherapy that he was invoking here was what we call innate immunity. It's a cytokine storm that precedes the formation of antibody-forming cells and cytotoxic T cells. It's the fevers and chills you get when you have your flu shot. Well, I got mine last night. I don't know about everybody else, but I usually get a few. I usually don't respond terribly well in that way. But you know what they say, no pain, no gain, so that's a good thing. So over the next 43 years, from 1893 onwards, he treated nearly 900 patients, and these bacteria became known as Coley's toxins. He achieved remarkable success, and in fact, it's still a Coley's toxin is still used today. Live BCG, which is a vaccine form of tuberculosis, is used for bladder cancer still. It fell out of fashion because with the advent of modern chemotherapy, it sort of took over, and it was felt that in a lot of cases, infecting someone with these very toxic bacteria has some mortality associated with it, shall we say. So what are the approaches? I'm going to run through the major approaches to cancer immunotherapy. And so there's adoptive immunotherapy and active immunotherapy. Adoptive immunotherapy is when you augment the immunogenicity of patients' own cells ex vivo. So in other words, you take immune system cells out of the patient, you manipulate them in vitro, and you put them back into the patient. And CAR T-cell therapy is perhaps the most famous application of this. And another form of adoptive immunotherapy is to passively transfer engineered antibodies. This is antibodies to antigenic display on the tumor, when bind those antigens and kill the tumor that's expressing them. And these are also manipulated in vitro and usually made from mouse monoclonal antibodies, which are then humanized. Both of these forms of immunotherapy, and then there's the field I work in. Please let us not forget that. And that is active immunotherapy. So the thing about how that differs is you're using the patient's own immune system. You're not manipulating anything ex vivo. You're relying on the fact that the patient, even though they might have undergone a lot of immunosuppressive therapy, still has enough of an immune response left that if you can jumpstart it, they will respond to their own tumors. And the new checkpoint inhibitors that have gotten a huge amount of press belong to this category. And the cancer vaccine field, which is the field that I work in, which is using some of the approaches that we use for vaccines against infectious disease to deliver tumor antigens. The hope is that you can mount an immune response that can eliminate the tumor using the patient's own immune system. So these are two separate categories. They're both predicated on antigen discovery, which is finding out what those antigens are expressed by a tumor that make it different from a normal cell, so that you can then apply either adoptive or active immunotherapy against those tumor antigens. And I just showing you here a few identified tumor antigens, and they're very different. They all come from different tissue sources. Let me ask you, how many people in here are scientists? Well, quite a few, but not everybody. Okay. Peter can't remember whether he's one or not.
I couldn't believe you said how many are scientists, because I just assumed most of them were.
Well, I think we're wrong. But how many of you who are not scientists are having trouble following?
Did you say that again?
How many who are not scientists are having trouble following? Good. We will proceed. Good. Okay. So these proteins that are expressed by human tumors, and there are many more than this is just a sampling, come from mutations, come from oncogenes, like P53. Sometimes they're tissue-related antigens. They're just found in a particular tissue that can be disposed of. A very good example of that is melanoma, which is a malignancy of melanocytes. And melanoma is actually quite immunogenic in and of itself without any intervention. And you can direct therapy against the enzymes in melanoma that actually make melanin, that make the black pigment. And when you do that, what happens is you get an autoimmune disease called vitiligo. Have you all heard of vitiligo? Michael Jackson was supposed to have had it. But he doesn't explain that strange thing he did to his nose. And but would you rather have vitiligo or would you rather have cancer? Would you rather have melanoma? I think I'd rather have vitiligo. And then there's some cell surface mutated receptors such as HER2/neu. I'll be talking more about that. And then there's some transforming viruses that produce oncogenes. And human papillomavirus is a very well-known one that is responsible for pretty well all anogenital cancer. And I'll be talking a little bit more about that later. So. All right. So what is the best way to use the immune system to fight cancer? There are two arms of the immune system, of the adaptive immune system. This is the immune response that kicks in several days after you've been infected or the body has been exposed to an antigen. And they are called, the adaptive immune system consists of T cells and B cells. And B cells are these little Y-shaped guys, make these little Y-shaped guys, which are antibodies. We've all heard of antibodies, we know what they are. Antibodies can bind to cell surface antigen or soluble antigen. They can't bind to antigen that's within a cell. And a lot of tumor-associated antigens aren't expressed on the surface of the cell, so they cannot be the target of antibodies. But any antigen that's made in the cytosol of a cell by normal protein synthesis, and that whether or not it then egresses to the surface of the cell, or stays in the cytosol, or goes to the nucleus, which oncogenes will traffic to the nucleus, they all get broken down and into fragments, and these fragments are then maybe I can use my pointer here. These fragments, yes?
I'm one of those non-scientists.
Yes? This is going to be the most difficult slide of all.
What those abbreviations mean?
Oh, okay. AG means antigen. NUC means nucleus. T cell means T cell. They're derived in the thymus. That's why they're called T cells. And then these are just various tumor antigens, some of which I've spoken about already. So any antigen that's made on a ribosome, misfolded versions of it will be formed in the cell, and these get broken down in a pathway which then lowers those fragments from the antigen onto the surface of a molecule that's sometimes called MHC, major histocompatibility complex, sometimes called HLA. And these are transplantation antigens. The purpose of these molecules are absolutely to present these fragments to the immune system. They also serve, they're also recognized within a species. So when you get immunosuppressed for a transplantation, a kidney transplantation, it's in order to stop the recognition of T cells of those foreign MHCs that came in with a tissue graft, okay? But the purpose of these is to stimulate T cells, and T cells derived in the thymus, and they're killers. They go out and they kill cells that they see with this antigenic display on the surface. And this could be tumor cells, or it could be, say, viral infected cells. There are other signals that this cell requires to become activated, which are just represented by an arrow. There are many, many, many of them, and I'm not going to go into all of the interactions that take place, but checkpoint inhibitors actually work at this level. So I just want to point that out before I get into describing those. So let's talk about augmenting the effective function of patients' own T cells ex vivo. So before CAR T cells were invented, there was a lot of research, particularly I would like to say Steve Rosenberg at the NCI, who recognized that if you could activate a patient's own T cells ex vivo and reinfuse them back into the patient, that these could possibly be effective against cancer. And Rosenberg's been doing this for years. And he's using a conventional T cell. So this is a T cell, just like this guy here. Just like this, a conventional T cell that recognizes the tumor antigen fragment in the context of the MHC and receives signals to be activated. And before CAR T cells, there was a lot of work done on whether you could reprogram that regular T cell. One idea was to tune the T cell receptor, that molecule that interacts with the antigen display. Another was making it more able to grab onto and be activated by that antigen display. One of the problems with that is that T cells are serial killers. So when they see this and they kill the tumor cell, it takes about 5 minutes. They disengage and go off and kill another cell. And you want that. You want them to be serial killers. They're going to need less T cells to kill the same number of cells if they're serial killers rather than monokillers. So they have to disengage, and sometimes T cells, these retargeted T cells with high affinity for that complex, were not able to disengage, and so are not as effective. So, and then another major thing is cancer is clever. So, here's an immune response to cancer. So after primary treatment or even secondary treatment cancer, it often recurs and you get relapsing. If the cancer recurs after chemotherapy, it's chemo-resistant. You have to try a different chemotherapeutic agent. If it recurs after radiation therapy, it's radio-resistance. If it occurs after immunotherapy, very often the cause of that is the downregulation of this MHC molecule here. So that gets internalized by the tumor cell. They become bare of these molecules that can interact with T cells, and the therapy doesn't work anymore. So Carl June and others, not the only one, but he's ours, so I'll mention him by name, decided it would be clever to try and manipulate T cells so they don't require this interaction with that MHC molecule. And to do that, he said, let's make them more antibody-like. Let's try and put on the surface of this T cell an antibody molecule that would bind to these cell surface tumor antigens, send a signal to the T cell to kill. So that's the challenge. You need what are called chimeric antigen receptors, which are based on antibody recognition on the surface of the cell, that can bind cell surface tumor antigens, not in the context of MHC, and kill. So they start off with, so now we're going to talk about CAR T cell therapy. They start off with this fragment. So these Y-shaped molecules are antibodies, and the business end of them that binds to the antigen is this end here. All right? So they make these fragments and to a cell surface antigen. It could be a growth factor receptor, or it could be any molecule that's expressed on the surface of that tumor cell and is not normally expressed on normal tissue, because you don't want these guys going around killing normal tissue. It's all about trying to keep it specific. And so this is also a very complicated slide, but this is also the second most complicated slide I'm going to show. So this is a CAR T cell, and here we have the tumor cell. It has a target structure on the surface. It could be a growth factor receptor. It could be any kind of surface molecule, as long as it's limited in its expression. Here is the CAR T cell receptor. So it's an antibody fragment, but then it's attached to the signaling molecules that the T cell receptor normally uses to signal lytic activity and production of cellular molecules that can kill the target tumor cell. Okay? So this is how they make CAR T cells. There are some challenges with it that I will go into. And this is how it is used. So the patient comes in to the hospital, you remove the T cells, okay? You then manipulate them in vitro to make more and more of them. You put in the chimeric antigen receptor. You go back, the patient comes back into the hospital, and you reinfuse in those CAR T cells that you made from the patient's own T cells, okay? And the very famous clinical trial that was done, that I'm sure you've all heard about, is the RAT19 protocol that Dr. Julian Porter did for chronic lymphocytic leukemia and acute lymphogenous leukemia. And it's called RAT because they're redirected autologous T cells, and they are directed towards a molecule called CD19, which is found on leukemic cells. It's also found on normal cells. So one of the downsides of this therapy is that you lose those normal cells with the immune system by using it. So the patient comes in, they take out 10 to the 8 cells, they incubate those cells to expand them. They use a virus to put in this chimeric antigen receptor. They put it in, and then they take it, and then these 10 to the 11 cells, they've increased them by 1,000-fold, are infused back into the patient. And as you know, this has been very, very successful for many patients. Not everybody. It's somewhat toxic, so there's been some adverse events associated with this, including death. It's about the biggest adverse event of all. But, these are very sick patients, and I'm sure you've all read the reports, so I'm not going to go into a lot of details about the results. There are some challenges with this kind of therapy. One is that they're not effective against solid tumors. So far, CAR T cells have been effective against leukemias. I like to call them liquid tumors. They're blood tumors. They're found in the blood. They don't form a solid tumor, such as colorectal carcinoma or lung cancer, cervical cancer, most cancer, to be quite honest. And as yet, CAR T cells have not been effective. They're working on it, but they have problems homing and penetrating tumor. So clinical trials using CAR T cells with solid tumors have been really quite unsuccessful. The second is that there's issues about using antigens where the tumors could shed the antigen, even though it might be bound to the surface. This soluble antigen can be circulating in the blood, and then you can bind the CAR T cells and block their ability to bind to the antigen that's on the surface of the cell. There's some immunogenicity associated with them, which can result in poor engraftment. In other words, you can mount a response to the cell itself. And they have shown immune responses against the mouse antibody sequences that they use for the receptor, antibiotic selection system, the fetal CAR serum that they grow the cells in, and the fusion joint between the antibody receptor and the T cell receptor sequences. And then, they're still juggling with receptor expression levels and how much CAR T-cell receptor on the surface of the T-cell is the most effective. So there are challenges to be met, but people are working on them as we speak. The other adoptive approach to cancer immunotherapy is to passively transfer antibodies to cell surface expressed tumor antigens. And this is perhaps one of the oldest forms of immunotherapy for cancer. And several of these now have been in the clinic for quite a long time. Herceptin, for example, made by Genentech, is against an epidermal growth factor receptor that's overexpressed on some breast cancer. It's been approved, it's now entered the clinic. There may be women in this room who've had breast cancer who've had Herceptin. Non-Hodgkin's lymphoma is a target for an antibody called rituximab, anti-CD20, which binds to B cells and eliminates all B cells, not just cancer cells. And actually that is also being used, rituximab is also being used now for rheumatoid arthritis that's caused by antibodies. And Erbitux is an antibody made by Imclone System. It's against another growth factor receptor, and it's used for head and neck and colorectal cancer. And the way these antibodies work is they bind to the surface of the tumor cell, and they activate immune system cells that recognize those antibodies and kill the cells. So most of them are toxic, cytotoxic to the tumor. Not all of them, but most of them are. Okay, now let's go to an area which is dear to my own heart, which is active immunotherapy. Is everybody okay with where we are so far? We're all following along? Okay, not too fast, not too slow. What about our non-scientists?
I haven't understood the last 6 slides, but go ahead.
Okay.
You're teaching an economist, not a biologist.
Sorry. I tried to turn it down a bit.
Oh, that's done down.
Yeah, no, I didn't say that. Okay. I don't think yes. It may not get any easier, but thank you for hanging in there. I really appreciate it. Active immunotherapy. So here what we're doing is we're using the patient's own immune system. We're not relying on manipulating it outside the body and putting it back in. And this is the 2 types of immunotherapy that I'm going to talk about for active immunotherapy are use of what they call checkpoint inhibitors. These augment the natural immunogenicity of the tumor by manipulating cell-cell interactions between the T cells and the tumors. And the second is to deliver a shared tumor antigen. This is an antigen that's overexpressed in a wide variety, in most people who have that kind of tumor. Okay, so here you could use one immunotherapy for all patients who have that kind of tumor. It's not a personalized form of medicine as CAR T-cell therapy is. And this is sometimes called cancer vaccines. So, Dr. Economist, I know you're going to love this slide. But I think it's kind of important. So T cells, I told you about how the T cells see a tumor. Here's a tumor cell, here's the T cell. You don't need to know what all these guys are here. Don't worry about it. Here's a T cell receptor I talked about, and the MHC I talked about. And this is a cell that activates T cells, and this is how the tumor cell interacts with T cells. And in addition to this major interaction between the T cell receptor, the MHC and antigen, there is this molecule called PD-1 on the T cell that binds to PD-L1 on the tumor cell. It can be on the tumor cell, it's also on the dendritic cell. And that interaction is a negative interaction. It's a checkpoint. It puts a brake on the immune response. And it's there for a purpose. It's not there to be a nuisance to cancer immunotherapists. It's there because you want brakes on the immune response. After you've been infected by a virus and you've activated all these T cells and you've eliminated the virus, you don't want them out there anymore, potentially interacting with normal cells. So this is a checkpoint, and the checkpoint inhibitors are antibodies that block this interaction. That's what they do. Here are some of them. Ipilimumab, anti-CTLA-4, Keytruda, which is an antibody against PD-1, that part of the interaction, and then Opdivo, which is an antibody against this part of the interaction. And these are just 3 of them. Actually, there's quite a few of them now. They call them biosimilars, in that a lot of the drug companies have sort of jumped on the gravy train and started making their own versions of them in order to cash in on this immunotherapy. I'm not trying to be cynical about this. It's just a fact. But these are the 3 main ones that you will have come across, and if any of you have the misfortune to get cancer and offered immunotherapy, these are the ones that you're likely to be offered. And nowadays are actually doing clinical trials that are combining 2 or more of these. So that's the way they work. And they've been, I would say, quite successful. Jimmy Carter's an example, who received this treatment and is now cancer-free. But in terms of sort of median survival, it's not as striking as that single example. So now we're going to talk about, this is the last immunotherapy I'm going to talk about, and it's cancer vaccines, and this is what I work on. So what is a cancer vaccine? So it's a way to harness the natural immune response to tumours by active immunisation using similar strategies that have proved effective for prophylactic vaccines against infectious disease. Pretty simple, right? Now, as we learn more about the genes that predispose individuals to specific cancer, prophylactic vaccines may also become a reality. And we do have an example of a prophylactic vaccine. It is Gardasil, or Cervarix. It's called, Merck's version is Gardasil, GlaxoSmithKline's version is Cervarix. This is a vaccine to stop people getting infected by HPV-16. HPV-16 is a nuisance, or not HPV-16, but HPV-transforming viruses. There's a whole bunch of them, about 14 of them. And HPV is not a serious disease. It's a sexually transmitted disease, but it's a virus that immortalizes cells. Those cells can receive a second signal, transform, and cause malignancies. And it is the leading cause of cancer death not the leading cause of cancer, well, it's the leading cause of cancer death in some countries for women, cervical cancer. So how can we jumpstart the immune response using vaccine approaches? Well, there are many ways people are working on this, but I'm going to tell you about the way I'm working on it. So one way of doing it is to take this tumor antigen that is not very immunogenic, often it's very similar to self-antigen, and wrap it up in such a way that the immune system thinks it's dangerous. In other words, put it into a vector, a viral vector or a bacterial vector. And then the immune system is going to respond to those infectious agents, and at the same time will respond to this recombinant antigen that you've put into the vector. And therefore it's a way of fooling the immune system into thinking this mild antigen that it doesn't normally respond to very well is dangerous and you better wake up and do something about it. So I am going to talk today about the only one of these vectors that's in pink, because it's my vector. So I'm going to ignore all the other approaches and go right into my vector. I happen to think bacterial vectors are safer than viral vectors. The good thing about bacterial vectors is that we do have many antibiotics that they will respond to. So if an infection gets out of control in a patient, you just go in with, in the case of Listeria, penicillin. You just go in with penicillin. It's that simple. Not the case with viral vectors, as we at the University of Pennsylvania know the hard way. So I think that bacterial vectors have that advantage. Viral vectors have the advantage, however, that they are very good at making these cytotoxic T cells, these killer T cells that I've told you are really key in terms of cancer immunotherapy. Bacteria are very good at stimulating innate immunity. That's the initial immune response that occurs in the first 2 or 3 days, which kickstarts the adaptive immune response, and was the type of immunity that the coldest toxins were directed against. But Listeria is interesting because it not only has the ability to generate this innate immunity, it also has the ability to give you very strong cytotoxic T cell responses, more so than most other bacteria. And the reason for that is because it lives in the cytosol of the cell. So Listeria is a gram-positive intracellular bacteria. It's a foodborne pathogen. You've all heard of, Listeria contaminated melon, watermelon, and so on. What's different about it is when it gets taken up by a phagocytic cell, it has virulence factors it produces that break down the phagocytic vacuole, and it escapes into the cytosol of the cell. And of course, once it's in the cytosol of the cell, any antigen it makes, including a tumor antigen, is going to get into that pathway I've already told you about, where it gets broken down into fragments and put on the surface of the cell, bound to MHC, where it can activate CD8 T cells. So Listeria is very good at doing that. And when I found out I could do that 20 years ago, that was when I started working on using it as a vaccine vector. Here's a little micrograph. This is like a little low-tech picture of Listeria inside the cell. You can see here, replicating, doing what it likes doing the most, which is reproducing. And here you can see it spreading from one cell to another. We use Listeria strains that are highly attenuated. We've manipulated them so that they're much less pathogenic than the wild-type strain. And we've also developed genetic tools for transforming them to make these tumor antigens. So I'm going to tell you about one study, in the next 10 minutes, that we have done, because although we've used this bacterium as a cancer vaccine approach to quite a few different cancers now, the one that's furthest ahead is a therapeutic vaccine for human papillomavirus in transformed cells. Now, here's more about human papillomaviruses than you care to know. I realize that, but that's all right. It's a causative agent, pretty well all anogenital cancer, and about 25% head and neck cancers. It's the second most common cancer in the world for women. There's a little bit about it. It's a DNA virus. There's over 100 serotypes. It infects skins and mucosal epithelial tissues. There are some low-risk papillomas that just give you benign proliferative growth or warts. And then there's high-risk types which are associated with malignant lesions. The prophylactic vaccines are out. Everybody's using them. My oldest granddaughter just got her first shot, I'm pleased to say. There are two versions of it. The Cervarix, which is GlaxoSmithKline, and that targets 16 and 18. 16 and 18 are responsible for about 70% of cervical cancer. And Gardasil targets 16 and 18, and 16 and 11 responsible for most genital warts. They are recommended for both boys and girls because it takes two to tango. And this is a sexually transmitted disease, so I recommend that you get your grandsons and your sons vaccinated as well. So I'm going to tell you about a phase 2 trial, because I'm calling this vaccine LM for Listeria monocytogenes, LLOE7 for the antigen that it's delivering. And this is a trial that was performed by Advaxis Immunotherapeutics. And I do have a conflict of interest slide at the end of my talk, but I will tell you right up front now, I have a significant financial interest in this company. I have many patents. Penn has many patents. I don't have them. Penn has them that are licensed to this company. So I do have a conflict of interest. So if you feel that means you can't believe a word I say after this, feel free to walk out. I'm fine with that. So, there were two arms. In one arm, they got just the vaccine. So these are women. Let me tell you who are entering this trial. These are women who are suffering from recurrent, unresectable, metastatic cervical cancer for whom all other therapy has failed. They have a life expectancy of 6 months. I'm sorry, I kind of choke up sometimes when I say that because no woman should ever get cervical cancer. And if we had worldwide screening, it wouldn't happen at all. But we don't. So this is what happened. This trial actually took place in India. So one group just got the vaccine 3 times. Another group got chemotherapy first and then the vaccine 3 times. And then they were followed up. They had a lesion that could be followed, and we looked for residual disease and, of course, survival. Cancer clinical trials are often all about survival. So, long story short, it was 100 patients entered into this trial, but I think only about 67 of them, I think, actually completed the trial. So we got 6 complete responses. That means they were cancer-free, and 6 partial responses. We found that tumor responses observed in the patients were infected with many different high-risk HPV strains. So we're seeing a cross-reactive immune response, even though we were only delivering the HPV-16 strain. These were seen in patients previously with chemotherapy, radiotherapy, or both, and surgery. We found there was no difference between the groups. Giving cisplatin giving them another round of cisplatin did not improve survival. And this is the very increased survival. We had 18% of patients alive, 24 months, including those that were in complete remission, 22% to 18 months, and 32% to 12 months. This is now in phase 3 clinical trials. So we're very excited about that. Adoptive Immunotherapies has a lot of trials ongoing at the moment. Cervical cancer, as you can see, is the one that's furthest ahead, that I'm very excited about. They're seeing very good results in that. This is a publicly traded company, so I have to be careful what I say. They're also using that particular. By the way, this is a horrible name that the FDA gave it. I can barely even pronounce it. Acrylamidine phylolyspec. Ouch. Anyway, and it's also being used for anal cancer with support from the Farrah Fawcett Foundation, and that's in phase 2-3 as well. There are some indications where they're using it together with checkpoint inhibitors, not all. There's a prostate cancer vaccine that's in phase 1-2 trial for prostate cancer. And then there's a vaccine that expresses HER2/neu that is in a phase 1 trial for all any tumor that overexpresses HER2/neu. And there's a proportion of many cancers where that is the case. Breast cancer, ovarian cancer, osteosarcoma, colon cancer. A proportion of these patients overexpress HER2/neu. So this is where it's at. I'm very thrilled that maybe one day there will be a product and it will be in the clinic. I think I'm going to skip that. Here are some of the FDA-approved, accepted forms of immunotherapy for cancer. You can see there's a lot of them out there now. None of these are typical cancer vaccines. Some of these are checkpoint inhibitors, the ones in purple are checkpoint inhibitors. There's cytokine-based therapies, which I haven't talked about a lot. And there's various antibody-based therapies are in green, and green and red. So there's a lot coming down the pipeline. So the big, $100 million question is, how much does it all cost? And is it worth it? So now, maybe this will be of interest to the economists amongst you. So CAR T, it's complicated. I have to tell you that, particularly for therapies that are not yet approved, people are kind of a little bit coy about talking about how much it's going to cost. But the chief financial officer of Juno Therapeutics is said the estimates are as high as $500,000 to $750,000 to use CAR T cells. The antibody therapies that are out there and being used now, we can say is, we know how much they cost. They're costing around $70,000 to $100,000 for, and then it will depend on how frequently they get it. Sometimes for Herceptin, women who have breast cancer will be taking this for years at a cost of $70,000 a year. Checkpoint inhibitors. So the ipilimumab, the CTLA-4 targeting, is which gives a median duration of remission of less than 3 months, costs $160,000. The PD-L1 checkpoint inhibitor, a PD-1, PD-L1 checkpoint inhibitors are coming in at around $150,000 for 12 weeks. So that's for one round of treatment. The combined therapies that they're currently working on are going to be therefore around $300,000. So, brutally expensive, I think Time called it. I've read articles that suggest that it could be $1 million a patient to keep a patient alive using various combinations of immunotherapy. So I think we all have to ask ourselves whether society can in fact bear that kind of burden. One thing I can tell you, what I feel very strongly about, is that these are not therapies, I suspect, that's ever going to be used in the developing world. So let's talk about cancer vaccines, shall we? So cancer vaccines could be priced very low, probably less than conventional chemotherapy, which is currently about, and it depends on the cancer and how many, treatments you have and so on, but the estimates that I found are $30,000 to $50,000. You can make a shot of listeria for less than $5. So one shot of listeria expressing HPV tumor antigen could be made for less than $5. And you would need 3 shots of that for a patient with cervical cancer. So the listeria technology, there's a lot of interest in the listeria technology in the developing world, and it is big. Clinical trials are taking place for the cervical cancer all over the world. It's very, it's been licensed to a company in South America, it's been licensed to a company in India, and it's been licensed to a company that operates in East Asia. As yet, there's no product. So I can't really tell you how much it's going to cost. But I see them as being I would like to see them costing very little, particularly for the developing world, obviously. But I think what we have to remember is that success rates for new drugs are 0.1%. That's so from the initial invention through preclinical work to a product. And for INDs, IND stands for Investigational New Drug. It's what you file with the FDA when you want to do a clinical trial. Only 10% of the drugs that enter clinical trials become products. And even then, they may not be successful because you need to have the doctors prescribing them. And in the case of one of the very earliest forms of immunotherapy, which was another personalized cell-based vaccine for prostate cancer, improved survival by about 4 months. It was called Provenge, was approved by the FDA, but the company that was making it sort of went broke because a lot of doctors were not prescribing it. Again, it was another one of these 6-figure therapies. So, there are a lot of, I'm going to leave you with that thought. I mean, there are a lot of decisions that are going to have to be made in terms of who gets these brutally expensive treatments. And I hope that they do eventually live up to their promise. So thank you. My conflict of interest. I've got Peter first, and
Yvonne, the antibodies that you use that are coupled are these mouse-based?
so they humanise them.
What?
The antibodies. So the antibodies.
Are they mouse generating?
Yes, to begin with, yes. But then
there's a complex interaction called hammer, in which people who've been exposed to mice, for example, if you're, as a child, you kept mice, you developed human anti-mouse antibodies, which you carry for the rest of your life. No, there are no consequences. There are thousands of people with human anti-mouse antibodies. There's nothing. The only time it comes in is if you get injected with a mouse-based antibody.
well,
is that a problem or not?
yeah, well, so it is it was a problem, and even if you don't have hammer, because you will raise an immune response to those mouse antibodies. They humanize them. So then first they make a monoclonal antibody in the mouse. Then there are two ways of humanizing. In one case, they take that combining site, that whole combining site, which is about 200 residues, and they graft it onto a human antibody. All right. Then there's another more refined way of doing it. And to be honest, I can't tell you which of the antibodies are humanized that way and which are done the more refined way. But the more refined way of doing it is to just take the actual combining site, the fragments of the protein fold that interact with antigen, and graft those completely onto a human antibody. So this is not a problem anymore. They've kind of gotten over that.
I'm out of date.
Two things occurred to me, Yvonne. One is, what is the most expensive part of administering those drugs? It's usually expensive, it seems. Is there, I'm a non-scientist, as you well know, is there a part that should be sort of approached in some way to try to get the price down? Or?
That's a good question, Pam. I'm not certain I know the answer to it. I mean, part of the problem is the high failure rate of drugs, which I've tried to allude to in that slide. But the other thing is, you know, the personalized therapies are even more expensive because each of these is tailor-made to that person. Even so, that's not the whole answer, because the checkpoint inhibitors are not. They're not personalized. They're applied to anybody with cancer. And they're still about 6 figures. And I think that must be largely be developmental costs associated with them.
And also, you mentioned screening for cervical cancer, and how we're not doing it, and what a tragedy that is. What would you look for in a patient that would trigger the thought that cervical cancer could develop?
Well, there are some. I mean, we know, you know, we women who were fortunate enough to live in the Western world, you know, have our PAP screenings, and that's been tremendously effective in reducing cervical cancer. There are some approaches that are being used in the developing world where they use a sort of acetic acid solution to sort of light up the cervix. So this now the lesion is visible on inspection, and that's been shown to be very promising. Of course, you know, if we could get every young boy and girl in the world vaccinated, we wouldn't have this problem. But in fact, that's not going to happen. It doesn't look like it's going to happen. And there are 20 million women who have been infected with HPV in the world that are at risk for cervical cancer. This is why I think a therapeutic cervical vaccine is needed. Yes, Peter.
What is your thought about why only about 20% of the patients with cervical that were treated with the vaccine seem to respond? What happened to the other 80%?
Well, they all, I mean, not all of them responded, though there were a number of patients who, I actually took that slide up, a number of patients who got stable disease, right? The women wouldn't be, well, I mean, it's a mixed population. They would have had different treatments to begin with. Although they were all stage 3, 4, some of them may be more advanced than others. Some of them may have been healthier than others in the first place. That particular trial took place in India. Some of them may have had better access to medical facilities. So, but even having said all that, you know, even in the developed world, even here at the hospital at the University of Pennsylvania, you'll see different response rates.
Yeah,
We're all different. We all have different immune systems.
so do you think you're going to have to individualize vaccine for different groups?
Well, it may, you know, if one could stratify them, or it may be that some people might need more boosters than others. We did a study, which I didn't talk about, but it's kind of a core study, in the vet school, and this was a collaboration with Dr. Nicola Mason, who's a professor in vet school, where we did a clinical trial in dogs with osteosarcoma. And the standard of care for a dog with osteosarcoma is amputation followed by chemotherapy. And we followed that up with the vaccine that targets HER2/neu, which is overexpressed in osteosarcoma. And we saw fabulous results. I mean, we saw 5-year survivals for some of these. We only followed them out that far. It was 5 years ago we did it. Survivors of these dogs. I mean, 5 years is a third of a dog's life, right? But again, you know, not all dogs behave the same. Some is more effective in some dogs than others. Yes?
Why is CAR-T therapy not successful against the solid tumors and the active antigen, yours, Listeria, is found consistent in solid tumors?
We've only used it in solid tumors.
Yeah.
We've only used, so the Listeria probe has only gone into trials for solid tumors, right? So we haven't used it for leukemias. I don't know the answer to your first question. You know, CAR T cells are not my thing, but I think they seem to have problems getting into the tumor. That's what I've been told. And you know, they are actively working to try and improve that. Because if you know, for a liquid tumor, for a leukemia, they don't have, penetration isn't a problem. They just interact with the cells in the bloodstream and the lymphatics, and that's it. But for a solid tumor, you know, tumors encapsulate themselves. They set up their own blood supply. They get mixed with fibroblasts and other stromal cells. And so the challenge for immunotherapy really is to get the T cells into the tumor to kill the tumor cells. We've shown with the Listeria approach anyway that you get a lot of cytokines produce early infection which upregulate chemokine production by tumors. So the tumors now start making a chemoattractant, and that chemoattractant helps the T cells get in. So that's what I know about my technology and how it works. Yes?
I read in today's Inquirer that there was a Penn alum named Parker who just gave a huge grant to fund an immunotherapy.
Not me.
Not to, well, to the medical school and well, I assume that's going to be a big jump starting for additional research.
Yes, I'm sure we will. I mean, they've now got a whole institute devoted mainly to CAR T cells. Yeah, but yeah, I think there's still a lot of work to be done, and that's going to be very helpful.
How about the quality of life in the subjects who responded to the therapy? Like, if you take, for suppose, you take the chemotherapy, so you are extending the life of the subject, but the quality of life is not significantly improved. Like they have like darkening of the skin, losing of the hair, side effects. So So with this therapy, like the patients just responded, but they completely free of any side effects, or were there any side effects?
No, there are side effects, but they're different side effects, so we don't really care, so that's what. But, so with immunotherapy, the side effects are associated with the immune response. And so for these adoptive T-cell therapies, they get a huge number of cytokines produced. And cytokines which are produced by T-cells are sort of what make you feel sick when you get ill. You know, your temperature goes up, your blood pressure goes down, fevers, chills. And so for all immunotherapy, you see that. You see it for mine. It's worse for some than others. For the listeria approach, we have not had, I don't think we've had any adverse events much above 2. So fever, chills, hypertension, which is corrected by IV fluids, sometimes headaches, nausea, vomiting. In all cases, it's gone within about 3 days. And then if a patient spikes a fever that goes above, I think it might be, I can't remember exactly what it is, it might be 102, they're given penicillin. Okay, so that then ends the infection. They really only need to be infected for a couple of days to mount a good immune response anyway. So from the point of view of adverse events, the cancer vaccine approach is probably, I think, the most humane. Not just my approach, but other cancer vaccine approaches. Yes?
Could you explain again, very briefly, what listeria does?
Okay. So listeria belongs to a group of bacteria called facultative intracellular bacteria. So it can live aerobically and anaerobically. It's a contaminant of foods, and it infects through the oral route. It's not a particularly successful pathogen, because if you have an intact immune system, you really can get listeria without even knowing it. Well, the people who come down with listeriosis, with a fulminant infection of listeria, are usually immunosuppressed for one reason or another. It differs from very many bacteria, not all facultative bacteria of that type, in its ability and where it lives in the cell when it infects the cell. It tends to infect the cells that are responsible for presenting antigen to T cells. These are phagocytic cells that engulf, phagocytic comes from the Greek word to eat, right? Yeah. They're macrophages, dendritic cells. So they eat up the bacteria, but the bacteria has developed special proteins that allow it to break open the membrane of that phagosome and live in the cytosol of the cell, which is a very comfortable environment for it, because there's no microbicidal attack to it, it's got lots of nutrients, it's pretty happy in there. And it reproduces in the cytosol of the cell. So I reasoned when that was first worked out that listeria could do that, that if you could transform listeria to carry an antigen, you would get a very good T-cell response to the antigen, because it's in the cytosol of the cell that the antigenic fragments are generated. Does that answer?
Yeah.
Okay.
Thank you.